I'd like to start by summarising the round table that we've just shared with a number of other specialists on SLT. A number of very interesting points came out of this. The first was about the mechanism of action of SLT. The potential mechanism of SLT is not all that different from traditional laser trabeculoplasty, but the important difference is the dramatically lower amount of thermal damage. This has important clinical implications. It means that you're much less likely to cause peripheral anterior sneaking eye afterwards. While it is recommended to perform SLT in wide open angles, if you perform them in slightly narrow angles that are not occludable, you will not cause PAS, which you might do after ALT. It is still important to perform gonioscopy prior to performing SLT to ensure that the angle is not occludable. It also may affect the repeatability, because if there's much less thermal damage and less widespread destruction of the meshwork and still viable cells present, then there is a possibility of retreatment. The response to SLT is likely to be dependent on the degree of IOP elevation to start with. If a patient has very high IOP, the proportion, the magnitude of IOP reduction is likely to be much greater than that if the patient has a lower IOP to start with. This is especially true of the patients naive to medical therapy who get the most reduction from SLT. The obvious question then is, what about NTG? Do patients with NTG respond to SLT? Well, they do to some degree, especially those with pressures in the higher teens, but the response is less, as one might expect, than patients with high pressure POAG. Patients with exfoliation syndrome also respond to SLT, and they seem to develop roughly equal degree of pressure drop as POAG eyes do. The only difference is that with exfoliation syndrome, the pressure drop seems to be of a shorter duration than it is after POAG and SLT. The typical response time for a patient with PXF might be 1 year rather than 2 years. So close monitoring would be required afterwards to ensure that the pressure effect is not lost. Pigmentary glaucoma is another interesting type of glaucoma that is not uncommon, and it is especially interesting in relation to SLT because the high level of pigment in the trabecular meshwork can affect the response to SLT. It is easier to overtreat a patient with pigmentary glaucoma with SLT, and therefore treatment needs to be performed with some degree of caution. Patients who respond well to PGAs also seem to respond well to SLT, but on the other hand, patients already on PGAs will not develop much of a further response to SLT as adjunctive treatment, but will get an equal response as replacement treatment. The drivers for using laser trabeculoplasty in clinical practice are interesting. Despite the glaucoma laser trial showing that argon laser trabeculoplasty was a superior treatment to medical therapy in naive patients, and despite better long-term visual field stability, argon laser trabeculoplasty has never really replaced medical therapy as initial treatment. It may be simply that laser trabeculoplasty at the patient's first visit is perceived by the patient as being a rather invasive treatment, simply because of the name laser sounds invasive, whereas in fact it's a very benign treatment. And it may be that it just takes some time to talk to patients and educate them about the potential costs and benefits, which in very busy clinics is demanding of physicians' time and requires a certain degree of infrastructure that perhaps is not always available. Cost effectiveness of SLT compared to other therapies in general in managing POAG. This is a difficult one because it may well differ in every single country where there are many different insurance and reimbursement environments. My initial thoughts are that in a country such as the United States with a very high cost of medical therapy, for those who are paying for medical therapy straight off, SLT would obviously be cheaper. There's obviously a fee-for-service element in performing SLT, and there's the cost of the laser itself. But unlike many types of equipment and procedures that we do, there are very low on costs from SLT. You don't need a new cassette or anything to put in the machine each time you do a laser. The laser is there, it requires annual maintenance. So that after the initial cost, the cost of SLT itself is relatively low for the physician or the purchaser of healthcare resources. The cost of ongoing treatment in terms of drugs is obviously much less for the patient after SLT than it is with patients on medical therapy. And that may have less impact in a country such as the United Kingdom, where patients largely don't pay for drugs, but it is a cost to the healthcare purchasers, the NHS. In countries such as the USA, where drugs are very expensive, it may make a huge difference. Interestingly, in countries such as in African countries or poor countries, it may make an even greater difference, where patients simply can't afford the drugs and there isn't any form of alternative healthcare insurance or provider. An SLT that reduces the pressure by a significant amount for a proportion of time may really help save a patient's sight. There are many other issues though in terms of cost effectiveness other than simply the cost of drugs, and a really important one is the cost of associated healthcare resources. It's frequently seen in drug company comparisons that changing medications, for instance, increases the frequency of visits and increases the cost of healthcare overall. So if you chop and change something, the patient needs to come more often, they perhaps need more tests, the cost of healthcare goes up. If you have a treatment that works for a longish period of time without the need to chop and change, you may find that you require fewer visits and less consumption of healthcare resources. Also, less inconvenience to the patient if they don't have to come so often. So there are other issues such as the time off work for the patient, the cost of transport to get to the hospital or to the physician's office that may be important. Finally, the most obvious benefit in terms of healthcare benefits for a patient after SLT is the compliance issue, the lack of inconvenience. You have an SLT, you don't need to take medications, you don't need to remember to put them in, you don't have the side effects, and this can be a substantial burden on the patient, and there is a huge potential benefit in terms of compliance and adherence with SLT versus medical therapy.